Good day. I would like to call this meeting to order. My name is Ann Aiken. I'm the acting designated federal officer for the National Vaccine Advisory Committee, or NVAC for short. There are a few things you should know before we get started today. First, this is a public meeting and it's being recorded. All statements made today are on the record. Second, this advisory council is governed by the Federal Advisory Committee Act, or FACA for short. FACA provides the rules about the circumstances by which agencies or officers of the federal government can establish or control committees or groups like this one to obtain advice or recommendations. The voting members are special government employees and are therefore subject to conflict of interest laws and regulations, as are all members who work for the federal government. These members previously provided information about their personal, professional, and financial interests. Each voting member's financial interest and outside affiliation has been carefully screened each year to ensure that they comply with federal ethics law. The liaison representatives are non-voting members of the advisory council and are not subject to the same FACA rules in voting as the voting members are. Additionally, the information provided at this meeting does not necessarily represent the official position of the National Vaccine Advisory Committee or the U.S. Department of Health and Human Services. Mention of products, processes, services, manufacturers, companies, or trademarks does not constitute its endorsement or recommendation by the U.S. government, HHS, or NVAC. So now that we've got that out of the way, let's proceed with roll call for the meeting today. I'm going to take the official attendance and call off each of the names of the NVAC members. Please verbally respond when I call your name. Robert Hopkins.
Present, glad to be here.
Melody Butler.
Present and good morning.
Good morning. Jeff Dushan. Okay, he's going to be attending online. Chris Arizman.
Present.
Good morning. Dan Hoft.
Present.
Good morning. Molly Howell.
Present.
Good morning. Jewel Mullen. She's on her way. Steve Rinderknecht.
Present.
Good morning. Rob Schechter.
Present.
Good morning. Winona Stoltzfus.
Present.
Good morning. Rob Swanson.
Good morning, present.
Good morning. Brenda Holbrook.
Present. Good morning.
Good morning. Chris Riegel. Claire Hannon. Rebecca Coyle.
Present.
Good morning. Mitch Rothholtz.
Present.
Good morning. Aaron Henry.
Present. Good morning.
Good morning. Christine Oshansky.
Present.
Mo Patel.
Present. Good morning.
Good morning. Captain Iskander.
Present.
Good morning. Jay Slater. Andrew Ford, or Barbara Mullock. Brenda Holbrook. Did I forget anyone?
This is Brenda. I'm present. Just mentioned.
Hi, Brenda, and Gita Swami's here at the table as well. So with that, I'm going to go ahead and introduce Admiral Rachel Levine. But before I do that, I wanted to just take a moment to thank Bob for his work and leadership, and then thank the team, including Rebecca Lazaration, Viola Jacobs, and Emily Downs. We have a few helpers here today: Susan Farrell, Hamill Groh, Allison Petkoff, Charnette McHugh, Renee Wilson, Valerie Marshall. I also wanted to thank the studio team. It's been super helpful. We have 3 sign language interpreters today. They're helping to make our meeting more accessible. We also have a note taker online and some great tech support. Skasha Morris and Stephanie Teller have both helped with meeting support as well. So it's my pleasure to introduce Admiral Rachel Levine. Admiral Levine will provide us with opening remarks in a moment. For those of you who don't know, Admiral Levine serves as the Assistant Secretary for Health. She is also Director of the National Vaccine Program. Admiral Levine became the first female 4-star officer of the U.S. Public Health Commission Corps and probably serves our country in uniform. She has a rich clinical and public health background that fuel her broad portfolio at HHS, including her efforts to increase uptake in immunization and increase health equity. As the Secretary for Health at HHS, she has this broad portfolio, and she's here today to share her insights with us. So I will turn it over to you.
Well, thank you so much, Ann, for that introduction, and thank you for your fantastic work, as well as all the staff and our whole team in the vaccine program. Thank you, Dr. Hopkins, for all of your fantastic work, and really everyone here today. I would like to welcome you, our NVAC members, all of our speakers, and others attending this meeting. It's great to see faces in the room, but also those online. In my role as the Assistant Secretary for Health, building a stronger foundation for immunizations is very important to me. The work that is done through the National Vaccine Program and this committee are critical, and I want to thank you all for helping us see the work through. And I was just talking with Dr. Hopkins and others. You know, I'm a pediatrician, adolescent medicine subspecialist. I graduated from medical school in 1983, 40 years ago. I was 7 when I graduated, and very precocious. And you know, nothing is more important in terms of our work for our children, but also adolescents, adults, than our immunizations. It is one of the victories of the 20th and 21st century in terms of medicine and public health, but challenges remain and new challenges come in terms of vaccine misinformation and disinformation that we all have to work against. But your work is so important. As we move into the fall and winter, we now have vaccines that protect against the 3 major respiratory diseases that we're facing: COVID-19, influenza, and now RSV. Can't tell you how many children I took care of with RSV and bronchiolitis in pediatrics over 40 years. These diseases place a significant burden on communities across the United States. Each year, the extent of these illnesses and the timing that the viruses circulate in the communities varies. So tracking the data is critically important. Already, the CDC has issued a health advisory about increased levels of RSV across parts of the southeastern United States. The CDC is also tracking new variants of COVID-19, including the BA.2.86 variant. And as in previous years, the CDC issues forecasts and tracking data that help public health practitioners monitor trends, rates of illness, vaccination coverage, among other data points. Vaccination against these respiratory viruses is very important for everyone, especially those who are at higher risk of developing serious complications, including young children, older Americans, of which I am one, and those with medical conditions. Protecting people, especially those most at risk for complications from these diseases, is a very important strategy to keep ourselves, our families, and our communities healthy. It also helps lower the burden that these diseases play in our healthcare system. Beyond the annual flu vaccine, new COVID-19 vaccines and RSV vaccines will be available to the public, and the COVID-19 vaccine is now available to the public. As CDC's new flu vaccine information campaign reminds us, vaccines help take diseases from wild to mild, meaning that even if you get sick, they provide protection against serious infection and complications from these diseases. Working all together, we can reduce the spread and the severity of respiratory diseases. And I look forward to us using all of the tools that we have, all the tools in the toolbox, both new and time-tested ones, to prevent respiratory diseases this season and into the future. In addition to our focus on protecting against acute COVID-19, HHS is also invested in learning more about long COVID. People with long COVID can have a wide range of symptoms that may last weeks, months, or even years after infection. Sometimes the symptoms go away and come back again. These symptoms may be very hard for patients to manage as well as their families. We estimate that more than 7.7 million Americans have already developed long COVID. So to address this, we have recently announced the formation of our Office of Long COVID Research and Practice which is in my portfolio of the Office of the Assistant Secretary for Health. This office is charged with ongoing coordination across HHS, but really across the federal government on long COVID and associated conditions. We are working to implement the work that you have heard about regarding the National Research Action Plan on long COVID, as well as the services and supports for longer-term impacts of COVID-19. Currently, 14 federal departments are working on long COVID, including over a dozen groups at HHS. But we include the DoD, we include the VA, and many more departments. This work is centered on improving the quality of life for people living with long COVID and reducing health disparities. However, we need to work outside the federal government as well to address this complex public health problem. Through collaboration, we are actively listening to patients with lived experience, their caregivers and family, and other health workers to accurately address the long-term impacts that people experience. As we learn more about the role that vaccines play in protecting against long COVID, it is becoming clearer that COVID-19 vaccines prevent severe disease. Researchers at the NIH and beyond are working hard to understand who is more likely to get long COVID and why. These are important questions, and we are dedicated to better understanding long COVID and working to improve treatment and prevent cases from happening in the first place. We also still have work to do to get everyone caught up on vaccines that they may have missed or delayed getting during the COVID-19 pandemic. For example, last month, the MMWR published information about a study on vaccination coverage among adolescents aged 13 to 17 in 2022. 3 vaccines are routinely recommended for adolescents during this time to prevent tetanus, diphtheria, and pertussis, meningococcal disease, and cancers caused by human papillomavirus, or HPV. We have a cancer prevention vaccine, the HPV vaccine. For this report, CDC analyzed data from the 2022 National Immunization Survey of Teens. The analysis showed that for all adolescents aged 13 to 17, 2022 vaccination coverage levels did not differ from 2021 levels. Additionally, findings found lower coverage with the tetanus, diphtheria, and pertussis vaccine and meningococcal vaccinations by age 12, and lower DTaP and HPV vaccinations by age 14 among children born in 2008 compared with those born in 2007. These trends in lower vaccination rates are concerning. May have a variety of causes. In the wake of the COVID-19 pandemic, families may have missed wellness appointments with vaccinations such as DTaP when they were due. These data serve as an important reminder that we need to update people on their vaccinations, and this includes children, this includes adolescents, and this includes adults who all need protection. I ask that our immunization providers today and those who work with those healthcare providers think outside the box, they think creatively, and come up with at least 2 new steps to ensure that all their patients are up to date with their recommended vaccines. As many of you know from my previous remarks I have made at this meeting, I value all things that our healthcare workforce do to safely administer life-saving vaccines. Providers already do a lot on this front, but this data shows that we need to even work harder and continue to make improvements. Whether it may be reviewing tips from the 4 Pillars Immunization Toolkit from the University of Pittsburgh, which outlines new protocols to increase immunization rates in your practices, or signing up for continuing education credits from the American Academy of Pediatrics, online learning courses called EQUIP, to learn about continuous practice improvements on a number of topics, including immunization. It could be as simple as talking to a colleague about ways that they can successfully address catch-up immunizations. You all provide people with information about the benefits and risks of vaccination, and this is vital to making informed decisions. So thank you to all the immunization providers, all the healthcare workers, everyone on the committee who helped do this. Together, we can protect our communities through safe and effective vaccinations, and together we can work to dispel disinformation and misinformation about the safety and effectiveness of our vaccines. I want to thank our subcommittee members for their work on vaccine safety and innovation and information and immunization subcommittees. I look forward to discussions later today about this work, and I'm interested in learning more about the vaccine safety report that will be discussed later this morning. I sincerely appreciate your dedication and commitment to NVAC's charges, and once available to the thoughtful recommendations that you all make at NVAC to advance these essential facets of the immunization system. Thank you for your time today. I want you to know that your expertise is so necessary and so helpful to me, to our team, to HHS, and really to all of us as we strive to improve the public health of our nation. And this includes, of course, our vaccination efforts. And now I'm going to ask Dr. Hopkins to provide the chair's welcome. Thank you so much.
Well, good morning, and thank you once again for joining us for today's NVAC meeting. I want to thank you, Dr. Levine, for your thoughtful remarks and outstanding leadership. It's truly a remarkable time to work in immunization, and it goes without saying that the work you do at HHS exceeds expectations and inspires and helps us in our work. I want to thank Ann and the whole NVAC team for your work in planning this meeting and supporting the committee throughout the year. This includes all of the support for the two subcommittees that Dr. Levine spoke of in her remarks. Also want to thank the NVAC members and subcommittee members for their dedication to further the work of this committee. I look forward to the presentations and discussions today and tomorrow. I want to begin with a few remarks about housekeeping, and then we can move on to the review and approval of the minutes from the June 15th to 16th meeting, followed by a high-level overview of our agenda. In terms of housekeeping, I want to make sure everyone is aware that this is a public meeting. It's being webcasted on the HHS website. And I wanted to let everyone know that we have sign language interpreters available on the HHS live stream. I'd encourage people to speak slowly and clearly to assist them in doing their work as effectively as possible. Our interpreters help us to make this meeting more accessible, and I certainly think it's important to thank those sign language interpreters for their work. For our virtual participants, please remember to mute yourself when not speaking, and please do not use your camera unless you're presenting, asking questions, or answering a question. During our discussion, I ask that all members and speakers, both virtual and in person, identify themselves before speaking if I didn't acknowledge you by name before giving you the floor. This helps the note taker and others to follow along. Throughout the day, there will be opportunities for discussion. If you'd like to ask a question or provide a comment, raise your tent card in the room or send me a message through the chat feature for virtual attendees. Now I'd like to move to approval of our meeting minutes. The NVAC members previously received the minutes from the June 15th to 16th, 2023 meeting. Do any of the members want to make any corrections to those June minutes? Hearing none, could I get a motion to approve the June minutes?
I make a motion to approve. Melody Butler.
Thank you, Melody. Can I get a motion or second, please?
Second, Chris Ersman.
Thank you, Chris. All in favor, say aye.
Aye.
Okay. Do I have any noes or negative responses? Don't see any from online or in the room. Then our minutes will stand approved. Thank you all. Regarding public comment, as always, members of the public can provide a public comment by phone at about 4 p.m. today and at 2:15 p.m. tomorrow. Now, those are Eastern time. Public comments are not a question and answer session. They represent an opportunity for individuals who'd like to make a statement to do so. The deadline to request space for public comment during this meeting has passed. However, anyone can submit a written comment up to 3 pages in length to NVAC@HHS.gov. Now let's turn to a few highlights for our agenda for this meeting. For today, we have a wonderful lineup of speakers. We'll start with a discussion and vote on the Vaccine Safety Subcommittee report. Following the vote, we'll have a panel reviewing recent vaccine safety studies. And following a brief break, we'll hear some creative and time-tested ways trusted messengers have been used to help increase vaccine uptake. After this panel, our federal agency and liaison members will give vaccine-related updates since our last meeting. After lunch, we'll hear from experts discussing collaborations in immunization to improve collective impact. And then we'll hear a brief update from the Innovation and Immunization Subcommittee. We'll then have a panel on ways vaccination can help counter the negative health effects from climate change. And after a brief break, we'll hear about adjuvants and how they spur immune responses. We'll close the day again with public comment, as we mentioned earlier. Tomorrow, we'll open the day with a panel on inclusion in immunization. We'll resume after a break with a panel on creating a sustainable vaccine ecosystem. And just before lunch, we'll hear about several vaccines in development. After lunch, we'll resume with a panel on respiratory illness prevention, and our final presentation will be an update on the meningococcal disease type Y outbreak in Virginia. And the day again will conclude with public comment. Finally, as a reminder, please hold the 2024 meeting dates, as you see on the slide, on your calendars. Please refer to the NVAC website for final details on these upcoming meetings. And at this time, I'd like to invite Dr. Steve Rinderknecht and Dr. Rob Schechter, the co-chairs of our Vaccine Safety Subcommittee, to the stage, and they're going to discuss their work since our last meeting and review the draft report. Thank you again for joining us for our NVAC meeting.
Hey, good morning to the group. I want to start by just sharing my appreciation for being asked to be involved in this subcommittee. It's been a great honor. And I have had an opportunity to work with multiple different subject matter experts. And what's been really fun with this group is that we have had input in vaccine safety from people looking at it in many different angles. You can see here the public members that have been helping us with this group. And that's been fascinating to watch. All very interested in vaccine safety, but all approaching it from a different angle and a different background. So it's been really great for me to see that happen. I want to give special attention to Anne, who has kept us both on time and in line throughout this, and Rebecca Lazaration, who has helped with our technical assistance. Now just an overview of the charge that we were given. This was the ask that we were given by the Assistant Secretary for Health. Our ask was to review the last NVAC report on vaccine safety, as well as a previous vaccine safety scientific agenda and the vaccine safety goal in the strategic plan 21-25, and outline opportunities for continual improvement of vaccine safety activities during vaccine development, licensure, and post-marketing use. Our ask was also to make recommendations to address current and emerging vaccine safety challenges, minimize preventable vaccine-related adverse events, and improve all the individual components needed for a strong safety system. The next was to provide direction to improve coordination and stakeholder input into the timely detection and assessment of vaccine safety signals to better inform clinical decision-making and public health policy. The next was to describe science-based activities that HHS and federal partners can take to increase knowledge and use of the vaccine safety system, and to complete this by writing a succinct report summarizing the findings. Our final draft report contains 34 recommendations as well as a table. The table outlines both the strengths as well as the opportunities of our current safety monitoring systems. We divided this report into 7 main sections, and let me go through those. The first is a vaccine safety infrastructure section, which contains 6 recommendations. The next is on research and discovery, containing 5 recommendations. The third is vaccine safety monitoring of FDA-approved vaccines, containing 9 recommendations. The fourth is optimizing immunization information systems to improve vaccine safety. That had 3 recommendations. The fifth is reducing vaccine administration errors with 7 recommendations. The sixth is public communication with 4 recommendations. And the seventh is vaccine injury compensation, which we included just for its recognition of contribution to the whole system. Report development process. We met every other week as a group and worked on the tasks that needed attended. We heard presentations from various different authors, and acknowledgement of those people are on the next slide that we will show. The subcommittee then developed and revised a report outline first, and then we filled in the details of that outline to come in with the report. We updated the committee on the last 2 meetings here at NVAC, both at the February 3rd and June 15th meeting earlier this year. NVAC then provided guidance during those updates and provided edits that we included in this current draft. The current draft was then shared and sent out before this committee just a few days ago, I believe on Monday. If approved, this report will be submitted for publication in Public Health Reports, which is the official journal of the U.S. Surgeon General and the U.S. Public Health Service. I'm not going to read through this list, but I do want to share it with you. These are the folks that we heard from as we met every other week and received a really comprehensive look at the vaccine safety monitoring system at various aspects of its development and where we wanted to go with it. Now we'll jump into the recommendations themselves. The first 6 recommendations are in the category of infrastructure. Recommendation number 1, new and improved scientific and technological advances should be continually applied in support of vaccine safety research and surveillance. Therefore, NVAC recommends Congress increase vaccine safety funding in the next budget and consistently thereafter so that vaccine safety systems can nimbly evolve with scientific advances, new vaccine recommendations, and safety system changes. Second recommendation, NVAC recommends the Assistant Secretary for Health approve a charter and lead the development of a coordinating group within the federal government. Number 3, immunization providers fill a vital role in communicating vaccine safety information and immunizing people. NVAC recommends the Assistant Secretary of Health conduct a series of listening sessions with immunization providers to identify practical ways to reduce their workload in supporting the vaccine safety efforts. By reducing this workload, in supporting vaccine safety, more time would then be available to detect and assess vaccine safety signals to inform public health and clinical practice. Number 4, still in infrastructure, NVAC recommends HHS meet with interdisciplinary programs at academia, institutions to learn about training needs to support a new generation of vaccine safety experts and health communication specialists to support the ongoing educational needs of professionals in the field. Recommendation 5, NVAC recommends HHS collaborate with scientific, medical, and public policy groups to develop a robust community of people who can advise policymakers needing vaccine safety guidance. Number 6, NVAC recommends that HHS provide staffing and support that is adequate to both baseline and urgent needs, including developing flexible mechanisms for increasing vaccine safety, staffing, and funding during public health emergencies. Now we move to the category of research and discovery. There are 5 recommendations in this section. Recommendation 7, NVAC recommends the National Institutes of Health, industry, and other funding entities continue to support the basic research on underlying mechanisms of known and suspected adverse events and reactogenicity. This work can help increase understanding of the complex interactions between cells and molecules during the immune response. Number 8, NVAC recommends academics, researchers, and scientists continue to study the clinical signs and symptoms of specific immunological biomarkers, correlates of protection, and inflammatory responses to better predict, detect, and understand clinical symptoms or adverse events. This research can help predict side effects and improve immune responses to enhance vaccine safety. Recommendations number 9. NVAC recommends continued funding of research by NIH and other entities to improve knowledge of adjuvants. Recommendation number 10, with the goal of more quickly identifying rare adverse events and developing appropriate vaccine recommendations throughout the population, NVAC recommends HHS leaders meet to discuss ways to increase the number and diversity of participants in vaccine clinical trials. Topics for discussion include expansion of vaccine safety clinical trials to include more pregnant people, diverse races and ethnicities, people with comorbidities or compromised immune systems, and people with underlying allergies. Recommendation number 11, NVAC recommends the Assistant Secretary for Health meet with experts, including those from the vaccine industry, the NIH, the FDA, the CDC, and the DoD, and academia in the next year to find innovative solutions to expand vaccine safety activities, increase diversity in recruitment, and reduce the cost associated with executing large, diverse clinical trials. And I will turn the others over to Rob.
Thank you, Steve. So to continue on with the remainder of the recommendations, there are 9 recommendations around vaccine safety monitoring systems. Recommendation 12, NVAC recommends HHS to continue to invest in new methods to rapidly identify and monitor adverse events or preliminary diagnoses of adverse events, as well as provide reassurance when unexpected adverse events do occur. 13, the CDC should expand the number of healthcare organizations participating in the Vaccine Safety Data Link, or VST, and the Biologics Effectiveness and Safety, or BEST initiative to increase the ability and speed to detect potentially statistically significant associations between vaccinations and adverse events that warrant further investigation. 14, the CDC and the FDA should explore scalable solutions that reduce the time and effort required by clinicians to file reports with the Vaccine Adverse Event Reporting System, or VAERS, including potential opportunities for automation, such as auto-populating fields on the VAERS reporting form. 15, CDC should consider collaborating with partners to identify potential ways to increase enrollment and responses in the vSafe system. Let's see if I can, great. 16, given the promise held by the development of vSafe in evaluating the safety of COVID-19 vaccines, NVAC also recommends HHS continue to use specific funding and resources to expand vSafe for newly approved or authorized vaccines. 17, the CDC and the FDA should apply appropriate considerations when conducting disproportionality analysis for a vaccine of interest. For instance, if the researchers are studying an adolescent vaccine, they should consider comparison with another adolescent vaccine rather than all vaccines. Using an overly inclusive denominator can potentially obscure an imbalance in reporting of adverse events after vaccination. '18. Vaccine safety surveillance systems and partners should seek consensus on standardized case definitions for adverse events after vaccination, including search strategies for specified adverse events as appropriate. Harmonized case definitions and search strategies will better enable comparison of safety data between different domestic or international systems. 19, vaccine safety efforts and public health leaders in the United States should continue to collaborate with national and international partners to investigate adverse events and explore potential means of anticipating adverse events after vaccination. Global vaccine safety collaborations have become increasingly valuable in detecting rare adverse events. The Global Vaccine Data Network, which receives funding from public and private partners, can draw upon data for 250 million subjects. 20, HHS should invest in new methodologies, such as sequential analysis for rapid detection of signals, tree-based data mining for detection of unanticipated adverse events, and real-time identification of pregnancy status for the timely assessment of vaccination safety during pregnancy. Moving on to a handful of recommendations about immunization information systems. 21, NVAC recommends CDC and ONC meet with state groups to assess their IIS modernization and integration needs and provide federal funding to IISs to improve vaccine safety monitoring. 22, NVAC recommends CDC and ONC work together to develop model legislative language to share immunization and adverse event data bidirectionally between IISs and pharmacy information system interfaces. Given the strong relationships and collaborative know-how provided by the ASH, NVAC encourages the ASH to assist in disseminating and promoting this language once it has been developed. 23, NVAC recommends CDC and FDA vaccine safety leaders utilize IIS data in the Vaccine Safety Data Link and BEST systems. 24, to assist immunizers in accurate administration, NVAC recommends continued efforts by all manufacturers to clearly distinguish different vaccines and formulations through the designs of labels and caps or through other distinct differences in packaging. Coming after the COVID-19 vaccine, in which there were several lookalikes between cap colors and label colors, this recommendation has been made. An example would be color coding caps and clearly marking labels so that a variety of people could distinguish a pediatric patient dose from an adult patient dose. 25, NVAC recommends all people administering vaccines regularly educate themselves and follow precautions to minimize administration errors. For example, the Institute for Safe Medication Practices suggests using barcodes to confirm the correct vaccine has been given. CDC advises that immunization providers remove expired vaccines from storage units and other areas where vaccines are stored. The Immunization Action Coalition, immunize.org, urges immunization providers to use a checklist to identify patient contraindications and pinpoint precautions before vaccination takes place. 26, NVAC recommends all people who give vaccines take the CDC online training course, You Call the Shots, or equivalent training and review each year. The training, which is updated regularly to include the latest guidance and vaccine practices, includes timestamps to signify when the last update was made. 27, health systems, medical directors, and practice managers should encourage, track, and incentivize immunization providers to review training annually. 28, health systems, medical directors, practice managers, and vaccine providers should educate the entire healthcare system on new vaccine products, administration guidance, and vaccine recommendations when they are updated. This education should include effective communication techniques for healthcare providers when discussing vaccine topics with their patients. Moving on, or continuing with the last recommendations on administration errors, 29, NVAC recommends the use of updated standing orders or written protocols that are approved by a physician or other qualified healthcare professional to both reduce missed immunization opportunities in all patients and to ensure proper administration of vaccines. NVAC previously recommended standing orders to increase adherence to immunization schedules as an approach to reduce errors. Standing orders can be used to reduce contraindications, monitor for adverse events, or to improve administration adherence. 30, NVAC further recommends that all vaccine providers promptly report vaccine administration errors to VAERS. The National Childhood Vaccine Injury Act of 1986 requires both healthcare workers and vaccine manufacturers to report adverse errors that occur after vaccination, to report those into VAERS. Patients, parents of patients, caregivers, and others are also encouraged to report administration errors. Our last set of recommendations are around public communication. 31, to increase understanding of vaccine science and science in general, NVAC recommends HHS work with the Department of Education to add educational modules to health and science curricula in middle schools and high schools across the country. 32, NVAC strongly recommends that medical schools, nursing schools, healthcare worker training programs, pharmacy schools, and public health programs develop vaccine safety monitoring courses and curricula designed to improve understanding of the actual benefits and risks of vaccines and to ensure that all immunization providers are well-versed in vaccine safety monitoring methods and existing safety surveillance systems. 33, NVAC recommends continued research into vaccine safety communication. This research could include ways to improve awareness of vaccine risks and benefits, how to increase patient understanding of risk, and how to better counter rumors, falsehoods, and misinformation before they become widespread. And finally, 34, NVAC recommends increased funding and staffing for vaccine safety communications. Since the draft was shared at the beginning of the week, there is an additional edit for discussion regarding 29, the recommendation around standing orders. And the current wording is standing orders can be used to reduce contraindications, but suggesting a change that connotes verification or identification of contraindications rather than reduction of contraindications. And with that, we'll open the discussion to your comments. In closing, I want to echo Steve's thanks to Anne, Rebecca, and the NVAC staff, and Bob for his leadership. It's been a great pleasure working with Steve, Rebecca, and the other committee members. And we've been so fortunate to have those experts throughout government, academia, other sectors, and to have the panels of speakers over these last months. So thank you again, and we'll open up to questions. Thanks.
Thank you, gentlemen. We really appreciate the work of the subcommittee and your leadership of that subcommittee. Lots of hard work has gone into to this report, and hope we can bring it to a close very shortly. I see that Melody Butler has a question or comment.
I would like to make one quick comment. First off, thank you very much for this huge undertaking. This report, you can see it's tremendous, the impact it can have on the vaccine safety. I want to say I'm very happy to see you did include safety of vaccine administration. I know year after year we hear the most common complaint for vaccine safety side effects is SIRVA, shoulder injury related to vaccine administration. So I'm very happy to see that was included in the report, the recommendation for bringing additional resources and education to those who are administering vaccines. So thank you.
Any other questions or comments from those either in the room or committee members that are online?
John Iskander, Defense Health Agency. Yeah, I'd just like to commend recommendations 31 and 32. My soundbite for that is that we need to build, vaccine civics, and I think those recommendations are a really good start to that. I think one of the things we learned during the rollout of the COVID-19 vaccines was the low overall baseline knowledge of how vaccines are developed, tested, and monitored. So thank you for including those.
Thank you. Any other questions or comments around the recommendations themselves? If we could, do we have the ability to bring up the table for review? We'll give our team a moment to get that up. I had a couple of comments about that we might look at. All right, I see it on the screen. So this was the table of NVAC review of current post-licensure vaccine safety monitoring systems and projects. The first theme or project is around VAERS, and we've listed out the strengths. The final bullets says VAERS reports helped identify unexpected cases of rare blood clots after the receipt of the J&J COVID-19 vaccine. I might suggest that instead of pointing out a specific anecdote, as this is, that we might revise that bullet to the ability to detect rare and potentially unexpected adverse events. Might be a better way of driving that point home. This certainly was an important finding, but I'd rather focus on the theme rather than calling out one particular event. The second item, as we move down to the vaccine safety data link, the first bullet under the VSD and the second bullet are accurate. Under the second bullet, we've got VSD researchers demonstrated childhood vaccines have not caused autism or other developmental disabilities, as had been feared. That's an important citation, but again, that's an example rather than truly a strength of the system itself. And over to the opportunities and improvements. VSD data and capabilities can require additional training. Probably instead of can require additional training, might be additional training may help facilitate better use of VSD reporting. And then my final comment on the table is under the clinical immunization safety assessment, or CISA segment. Over in the opportunities bullet, with additional funding, the CISA project could perform additional clinical studies investigating vaccine safety topics in greater depth. CISA is already performing some studies, but additional funding would allow greater breadth in those opportunities. Thought those might be helpful modifications for all of us to think about. All right, any other questions or comments? Okay.
See if they want to.
Are members of the committee and obviously our chairs comfortable with those suggestions or comments?
I am. I think, am I on? I think those are very reasonable, and some of those examples, yeah, probably better in either footnote form or elsewhere.
Agree.
Dr. Hopkins?
Yes, please.
Can you restate your second one, please? I'm sorry, I got lost in the table.
Of course. The second comment was under the second bullet, under vaccine safety data link. The bullet reads, generates rapid safety assessments for routine and emergency vaccination campaigns. And then we had, following that, VSD researchers demonstrated that childhood vaccines have not caused autism or other developmental disabilities, as had been feared, which is really an illustrative example rather than truly a strength of the system. Any other questions or comments, either in the room or online? All right. If none, ceding to the chairs of the committee, if you all do not have any objection, I'd like to seek a motion from NVAC to approve this report. Is there a motion to approve?
So moved. Chris Hairsman.
Thank you, Chris. Do we have a second?
Second.
Thank you, Winona Stutzfuss. And I'd ask all in favor, please say aye.
Aye.
Aye. Okay. Are there any noes in the room? Turning to our committee members that are online as opposed to in the room, are there any objections or concerns from the committee members that are online?
Okay, so I'm going to go ahead and call the vote. Robert Hopkins, say yes, no, abstain, and then we can discuss if you have comments afterwards. Robert Hopkins?
Yes.
Melody Butler?
Yes.
Chris Arisman?
Yes.
Dan Hoft?
Yes.
Molly Howell?
Yes.
Thank you. Steve Rinderknecht?
Yes.
Rob Schechter?
Yes.
Winona Stoltzfus?
Yes.
Gita Swami?
Yes.
Robert Swanson?
Yes.
Is Jeff Dushin on the line? Okay. So we will count him as absent, and that leaves us 11 yeses. So thank you very much. If anyone wants to make another comment about their vote, please do so. If not, we'll conclude.
Well, I would take the chair's prerogative and again thank the members of the committee, the presenters that provided us valuable information to develop this report, and I look forward to this not only having been brought to our review and approval, but also look forward to its publication in public health reports. Thank you all for your work.
Thank you. Thanks.
So our next panel is examining the evidence to vaccine safety studies. We have two presenters for this panel. Dr. Matthew Daly will be online, and Dr. Nicola Klein is here in the room. In this session, two of our preeminent researchers will share information about findings from the vaccine safety studies. Dr. Klein, if you want to go ahead and come to the stage. Our first presenter is Dr. Matthew Daly from Kaiser Permanente, Colorado. And then our second presenter will be Dr. Nicola Klein from Kaiser Permanente, Northern California. Dr. Daly, are you on the line?
Yes, I am on the line. I just want to make sure you can hear me.
You are loud and clear. You have the floor.
Great. Thank you so much. Good morning, everyone. I'm Matt Daly. I'm going to present today on the childhood immunization schedule and safety studies in the vaccine safety data link. Next slide, please. I have no disclosures or conflicts of interest. Next slide, please. This is an outline of what I'm going to present today. We'll start by discussing the 2013 Institute of Medicine report, which examined the safety of the immunization schedule as a whole. We'll then discuss some feasibility work that was done within the Vaccine Safety Data Link, or VSD. I'll then review 3 published VSD studies that examined the safety of the childhood immunization schedule with different exposures and different outcomes within those studies. And then we'll finish with discussing some future investigations and place some of these findings in a broader context. Next slide, please. So as I mentioned, the Institute of Medicine issued a report in 2013 examining the childhood immunization schedule and safety. The subtitle of this report was Stakeholder Concerns, Scientific Evidence, and Future Studies. And the IOM report was done not because there were any known safety issues with the schedule as a whole, but because parents had expressed that the schedule was too many shots too soon. So the IOM concluded that existing evidence strongly supported the safety of the schedule as a whole. However, the IOM did highlight some evidence gaps. Each new vaccine was added to an existing schedule, and so safety studies were usually of acute adverse events, and long-term health outcomes were less well studied, and this was an area of concern voiced by the public, by parents. Some additional conclusions from the IOM report were as follows. The IOM concluded that randomized clinical trials, for example, comparing a group who received the entire schedule versus a group who received no vaccines, really was not a suitable approach to address research questions about the safety of the schedule for ethical reasons. However, the IOM did recommend that observational studies be conducted in existing surveillance systems, including the VSD. But they acknowledged that these studies were going to be really complex, and because of that, additional feasibility work was needed. One example of the complexity was sort of how do you define exposure to the schedule? It's multiple doses of different vaccines given over time, so that was one of the methodologic challenges around the complexity of doing these studies. And again, the IOM recommended that these observational studies focus on long-term outcomes. Next slide, please. So this led to something called the white paper. This was funded by the CDC, and it was examining the feasibility of studying the immunization schedule within the VSD. The VSD, as I know you're well aware, is a collaboration between the CDC and integrated healthcare organizations, and it conducts vaccine safety surveillance and research. The objectives of this white paper process, so the white paper involved subject matter expert consultation, as well as CDC input and input from VSD investigators. The white paper objectives were as follows. How to define the exposure, as I mentioned, how to define measures of the schedule which could be evaluated with a focus on the first 24 months of life. The white paper group also looked specifically at what different plausible adverse events could be studied in the context of the safety of the schedule, with an emphasis again on long-term adverse events, and then discussed key methodologic considerations. These outcomes were then prioritized based on their feasibility as well as public health significance and public concern. Next slide, please. The white paper group had some additional conclusions. They recommended that these studies focus on what they called high priority outcomes, including allergic disorders such as asthma, autoimmune disease such as type 1 diabetes, and neurologic disorders such as epilepsy. The white paper group highlighted the fact that some public concerns may have limited biologic plausibility, but if the concern was significant, that wasn't a reason not to undertake these studies. And then importantly, the white paper group had particular attention to the risk of bias in these studies and unmeasured confounding. And here are just some of the considerations and challenges around bias and unmeasured confounding. One concern was around misclassification bias. Perhaps kids who appear unvaccinated or undervaccinated in the VSD, in fact, have gotten vaccines elsewhere. This led to some surveys of parents in the VSD that confirmed that kids who appear unvaccinated or undervaccinated in the VSD, in fact, are. So there's misclassification bias. The white paper group also recommended using negative control outcomes, and this is a way to detect bias by looking at an outcome that couldn't plausibly be linked to the schedule, such as injuries, and then seeing if you can detect at least some forms of bias, such as underlying healthcare utilization. And then finally, the white paper group highlighted another really important point, which is that this is going to be a long and complex process. Any initial positive associations would necessitate follow-up studies to refute or replicate the initial findings. Next slide, please. So next, I'm going to move on and present 3 specific VSD studies that examined the recommended childhood immunization schedule. The first is a study of antigens and non-targeted infections. The public concern here, as I mentioned, was that somehow early childhood immunization is too many too soon, and somehow it overloads the immune system and then maybe produces more infectious disease later. So this study was a matched case control. The exposure was cumulative vaccine antigen exposure. And basically this is estimated by summing all of the antigens in each vaccine dose that every child in the VSD received from birth through age 23 months. And then the outcome was non-vaccine targeted infections. So all infections other than those that are specifically targeted by vaccines. So non-vaccine targeted infections in emergency department and inpatient settings from 24 to 47 months of age. And then some of these infections were verified by manual medical record review of a sample of outcomes, and then cases and controls were matched on age, sex, and presence of chronic condition. Next slide. So here are the results of this specific study. Among children with versus without non-vaccine targeted infections from 24 through 47 months of age, the odds of antigen exposure were not significantly different in the cases versus the controlled, with a match odds ratio of 0.94, confidence intervals which cross 1, so not significant. Secondary analyses were consistent with the primary findings. So then the conclusions of this specific study were as follows. There was no association between the number of antigens that young kids received through vaccines and then the likelihood of an ED or inpatient encounter for an infection. So again, this provided no evidence that the schedule actually does overwhelm the immune system, at least as measured by subsequent infection risk. Next slide, please. Now, this is a separate study, again conducted in the VSD, but with different exposures and different outcomes. So here the public concern, this is a study of the schedule in type 1 diabetes. So here the public concern was that something in vaccines, whether it's vaccine antigens or ingredients such as aluminum, which is used as an adjuvant, somehow interfere with the immune system and then increase the risk of autoimmune disease. This study was a retrospective cohort. 3 different exposures were examined in this study. The first exposure was cumulative vaccine antigen, similar to what I just described. The second exposure was cumulative vaccine-associated aluminum. And then the third exposure was average days under vaccinated. This is a metric that measures delay. So essentially, it's testing the hypothesis that kids who are vaccinated later maybe have less risk of type 1 diabetes. So again, it's how delayed a child is in receiving their vaccines, and then that's summed across all vaccines in the first 2 years of life. The outcome was type 1 diabetes mellitus. This was identified by diagnosis codes. These diagnosis codes have a high degree of accuracy at identifying true type 1 diabetes in VSD. The median length of follow-up in this study was more than 5 years. Excuse me, the mean length, more than 5 years. And then analyses were adjusted for sex, race, ethnicity, maternal age, birth weight, gestational age, and underlying healthcare utilization as measured by the number of well-child visits. Next slide, please. The results of this study are as follows. As I mentioned in the main analysis, there were 3 different exposures. Cumulative vaccine antigen was not significant. Average days under vaccinated was not significant. And then cumulative vaccine aluminum was inversely associated with the outcome of type 1 diabetes with an adjusted hazard ratio of 0.77. And the upper limit of the 95% confidence interval was 0.99, so it did not cross 1. Sensitivity analyses factoring in family history of type 1 diabetes were similar to the primary results. So the conclusion here was that the vaccine schedule was not associated with an increased risk of type 1 diabetes. However, there was decreased risk of type 1 diabetes at these higher vaccine aluminum levels, but it was a very modest effect size, and more study would be needed to refute or replicate this particular finding. But again, no increased risk of type 1 diabetes. Next slide, please. And then the third study I'm going to present today is a study around vaccine-associated aluminum and the subsequent risk of asthma. So here, the public concern was that vaccine ingredients, specifically aluminum, which is used as an adjuvant, increases the risk of allergic disorders such as asthma. There is some biologic plausibility for this hypothesis, although I describe it as fairly limited. Based on animal data, the aluminum in vaccines could potentially skew towards a T helper cell 2 or a Th2 type response. And then Th2 cells play a role in allergic asthma. And again, that's based on animal data alone. The design of this study was a retrospective cohort. The exposure was cumulative vaccine-associated aluminum received from birth through 23 months of age. Most vaccines have aluminum as an adjuvant. It's there to make those vaccines more effective, more immunogenic, but not all vaccines do. And then some children don't receive all vaccines, so this is what contributes to the variability in vaccine-associated aluminum, birth through 23 months of age. Here, the outcome was defined as persistent asthma at 24 through 59 months of age, and this was defined as follows: 1 inpatient or 2 outpatient diagnoses of asthma, plus 1 or more prescriptions for a long-term asthma control medication. And then all these analyses were done separately for children with or without eczema, because eczema is also an allergic condition. It occurs often diagnosed in the first 6 months of life, and it's strongly associated with subsequent asthma risk. Next slide, please. So in terms of the results of this study, there were more than 14,000 children with eczema. 6% subsequently developed persistent asthma between 24 and 59 months of age, at least as defined by our particular study definition. 312,000 children did not have eczema diagnosed in the first 12 months of life, and then 2.1% subsequently developed persistent asthma. The median vaccine-associated aluminum was the same in the 2 cohorts at 4.18 milligrams. Next slide, please. So this slide, I'm going to walk through this a little more slowly. This is the crude incidence rate of asthma by quantity of vaccine-associated aluminum. So the y-axis is persistent asthma per 10,000 person years. And then the x-axis is vaccine-associated aluminum in milligrams. The left panel is the kids with eczema, more than 14,000. The right panel is kids without eczema, more than 312,000. And then as you can see, with increasing levels of aluminum, there does appear to be increasing level of persistent asthma. Again, and this is incident persistent asthma as defined previously, and that's true both in the eczema cohort and in the no eczema cohort. Because of the scale of the y-axis, the increase over each increase in vaccine-associated aluminum in the right panel is a little bit harder to see because of the y-axis. But again, in both cases, it does appear that with increasing aluminum, there's an increasing risk of persistent asthma. And then this is crude, and what I mean by that is that it's not adjusted for any covariates. Next slide, please. So here are the main findings, and these are adjusted analyses. And again, this examines the association between cumulative vaccine-associated aluminum and persistent asthma. The first column are the variables in the model, and then there's additional covariates that are listed in the notes down below. Second column is the adjusted hazard ratio for the eczema cohort, and again, this is a separate analysis than in the no eczema cohort. And as you can see, the first row is vaccine-associated aluminum, so this is the main exposure, and there was an increased risk with a hazard of 1.26 in the eczema cohort, 1.19 in the no eczema cohort. And then the point estimates for a number of covariates are listed here, and these covariates, the association was of a degree and in a direction that would be expected by published literature. For example, males are more likely to have asthma than females, at least in this age group. Premature infants are more likely to be diagnosed with asthma, as are infants with food allergy or early life bronchiolitis. Next slide, please. So then the format of this slide is different. These are secondary analyses, and so I'll walk you through it. Each row represents a different analysis. And then the first column is the analysis, second column is the sample size for the eczema cohort, third column is the adjusted hazard for the eczema cohort, and then the next is the sample size for the no eczema cohort, and then the hazard for that. So the first row is the primary analyses, which are exactly the same as what was on the prior page. The next row is dichotomous aluminum, so looking at the exposure instead of as a linear or continuous variable, looking at it as a dichotomous exposure, more or less than 3 milligrams of vaccine-associated aluminum, and then the effect was positive, both for the eczema cohort and the no eczema cohort. Then we also looked at it excluding aluminum at the extremes, because maybe kids with less than 1 milligram or more than 5 milligrams of vaccine-associated aluminum are really different than the other kids. So we excluded sort of the high and low end, and the results are still significant, both for the eczema cohort and the no eczema cohort. We then examined a group of fully vaccinated kids. And so, again, everybody would have been fully vaccinated, and then the only variability in aluminum exposure would be just from the different products received. Here was not significant for the eczema cohort, but was significant for the no eczema cohort. The sample size is a little bit lower. About 62% of the overall cohort was fully vaccinated by 24 months of age. The next row is when we adjusted for breastfeeding, because breastfeeding may be protective against subsequent asthma. But only we only had data on breastfeeding for about 13% of the cohort, 13 to 14%. Here, the effect sizes were the point estimates were similar, but neither the eczema or the no eczema cohort was statistically significant. The next row was persistent asthma at 36 to 59 months of age. There was some concern that asthma diagnosed earlier might really be viral-induced wheezing and not asthma, so we excluded those who were diagnosed with asthma before 36 months of age, and here the results were significant for both the eczema cohort and the no eczema cohort. And then the last row is a negative control outcome. I mentioned this previously, that this is something we wouldn't expect to be associated with the schedule in any way, and it's a way to test for at least some forms of bias. We won't test for all forms of bias, but some forms of bias and confounding. And here there was no association between vaccine-associated aluminum and all-cause injury at 24 to 59 months of age. Next slide, please. So interpretation of this, there was a small positive association between cumulative vaccine-associated aluminum before 24 months of age and persistent asthma at 24 to 59 months of age. This finding was positive for children with and without eczema. In secondary analyses, there were positive associations in some, but not all of the secondary analyses. The study had a number of strengths, including a deliberate process with extensive feedback and study design, a large sample. We feel like the VSD has high data quality, but a number of important limitations. There was no data on dietary or environmental aluminum exposure, although there have been reports such as from the AAP that argue that little to none of ingested aluminum is absorbed, and so it may be less of a study limitation than it first perceived. In addition, there was no data on the social determinants of health. Certainly, there can be other sources of unmeasured confounding other than the ones we've talked about so far. Another important point is there really could be an antigen effect. For example, it could be that acellular pertussis, as part of a DTaP-containing vaccine, has some relationship to subsequent allergy risk. This is being studied, for example, in Australia, and that the aluminum is really just a proxy for antigen, and then there's an antigen effect on subsequent allergy risk, for example. As I mentioned, this is really the first step of a multi-step research process. Next slide, please. Here's some ecologic data to try to, again, help us interpret the findings here. So this is data provided from the CDC on asthma prevalence in kids less than 18 years of age. This is based on surveys, so it's based on parental report of asthma, although the question, I think, is worded, has a physician ever diagnosed your child with asthma? But in any event, it's a self-report. So as you can see from the 1980s to 2020, the prevalence of asthma increased in the United States steadily between 1980 and the mid-1990s. And then since around 2000, asthma prevalence has been stable, and then it's actually declined in the last several years. There was a gap in survey data between, say, 95 and 2000. And then a number of vaccines were added to the schedule during that time frame, including vaccines that contain aluminum. So this is ecologic data, and again, it's based on self-report, but no concerning trend of increase in asthma prevalence in the U.S. Corresponding to the addition of vaccines in the U.S. that contain aluminum. Next slide, please. So I mentioned further investigations. At the June ACIP meeting, Dr. Anders Avid presented data from the Denmark National Database that didn't see any association between vaccine-associated aluminum in Denmark and subsequent asthma in Denmark, although that comes with some caveats because their immunization schedule is a 3-month, 5-month schedule, and also has less vaccine-associated aluminum. So there were some differences, but there was reassuringly no association found in that database, and those were preliminary data, hasn't been published yet. And then there's a new study that's planned in the VSD with a larger cohort and likely examination of aluminum before 12 months of age, not before 24 months of age. And then based on some input we've received from colleagues, including asthma experts at the NIH, in this new study, we'll treat eczema as a covariate. And then probably the most important difference in this new planned VSD study and the one that I just presented was that there was concern, again, from external experts, including asthma experts from the NIH, that asthma diagnosed at 2, 3, 4 years of age may represent viral-induced wheezing and not true asthma. And so their recommendation was to examine asthma at a later age, such as 60 through 84 months of age. And then there are additional discussions and considerations about other data sources that could help assess this relationship. Next slide, please. So just to put, this is my last slide, but just to put the schedule and safety in some broader context, the totality of the available evidence continues to support the safety of the routine childhood immunization schedule in the United States. Existing federal vaccine safety surveillance systems, including the VSD, are responsive to the concerns expressed by parents of young children. And by responsive, I choose that word very, very particularly because, again, it was parent concern that precipitated the IOM report, and then the IOM report recommended these specific studies in the VSD and other systems. So by that, I mean responsive to these concerns. Again, as I said, precipitated by the report, there's a new field of study that's being developed looking at cumulative repeated exposure to vaccines and ingredients in vaccines, and then an examination of long-term health outcomes. And then at the time of the IOM report, very few studies had really studied the safety of the schedule as a whole. I practice as a primary care pediatrician, and if I was asked at the time of the IOM report, tell me about studies of the safety of the schedule as a whole, it was hard to sort of turn to any specific studies, even though I had confidence in the safety of the schedule. But now there are studies that I can specifically refer to. There is this accumulating evidence around these specific testable hypotheses, and then these results can be communicated to parents. I will highlight that the finding around aluminum and asthma, it was unanticipated, but we're continuing to work on that particular hypothesis as well as others. And the benefits of vaccination continue to strongly outweigh the known and potential risks. Next slide, please. So that's the end of my presentation, and I welcome any questions. Dr. Hopkins, I understand that we're going to take questions. Is it after Dr. Klein's presentation?
That's correct, Matt. Thank you very much.
Okay, thank you.
We appreciate your presentation. Nikki Klein, you have the stage.
Great. Thank you very much. Good morning. So today I will be talking about the safety of mRNA vaccination against COVID-19 in young children and the vaccine safety data link. Okay, and here are my disclosures. Thank you. So I think as all of you know, but just here's the visual of the vaccine safety data link. It was established in 1990 and is a collaboration between CDC, and at the time of all the studies that I'm presenting, it was 9 integrated healthcare organizations, but it has since expanded. But everything on these results and the studies are going to be showing just the data from the 9. So I'd like to just spend a minute talking about what I will be the rapid cycle analysis, or RCA. That I'll talk about and show the results of, but just to kind of give you the general framework. So the VSD, as I mentioned, is a population of approximately 12.5 million people from the studies, which at the time represent about 4% of the US population. And the VSD data are geographically and ethnically diverse. So the data that I'll be presenting are near real-time data with analyses updated weekly. And we have access to comprehensive medical records, including exposures, and vaccinations, and outcomes, allowing rapid chart reviews to obtain additional clinical information as needed. So one of the important advantages is that we can do innovative methods. And in this one, I'll be featuring is what we call the vaccinated concurrent comparators. And I'll walk you through it in a little bit. But just in general, we compare current vaccinees who are within their risk interval with recent vaccinees who are beyond their risk interval. And these can be preferable because preferable to unvaccinated controls because they adjust better for factors related to vaccination than historical controls, because they can also adjust better for factors related to time and setting, which was especially important during the COVID-19 pandemic when there's so many new changes that happen. And then self-controls, because they can adjust better for calendar day and also, importantly, also for the COVID-19 pandemic, for factors related to, they're more timely in terms of timely surveillance. And then in addition, we also did supplemental analyses, which we conducted weekly. We had unvaccinated boosted comparisons that were available to provide context. They were not reported regularly unless needed, but we did have them always available. So in particular, for the VSD COVID-19 vaccine rapid cycle analysis, the aims were to monitor the safety of COVID-19 vaccines weekly using pre-specified outcomes of interest, and then to also describe the uptake of COVID-19 vaccine uptake over time. And surveillance began in December 2020 and was ready when the first doses of COVID-19 vaccines were given. So these are all the outcomes that we monitor both in adults and children, which we'll be focusing on today. But this is a list of all of them. Anyway, so the outcomes, they're categorized in 4 groups generally, and that's how we chose them. The first one being generally inclusion of prior vaccine safety studies. We often monitor with these safety outcomes. We included outcomes that were hypothetical concerns regarding association with COVID-19 infection. We added outcomes that were added during surveillance after 2020 due to emerging concerns. And I'll just focus here that says one of them is myocarditis, pericarditis, which I'll mention later today. And that was one that we did add, but that was actually always on our list in addition because of the concern of association with COVID-19 infection. And then the 4th group was imbalance in phase 3 COVID-19 vaccine trials. Now those outcomes in red were those that we did not do analyses of. We did descriptive analysis, but we did not do weekly sequential analysis on. And then those outcomes with a green check mark, we chart reviewed and we only confirmed chart confirmed cases in the analysis. So this is the analytic plan. I think a number of you have probably seen these before, but for those of you who haven't seen this picture before, this is a picture of our analytic strategy using the vaccine concurrent comparators. Now on the top row, you can see this is an example of an individual with an outcome. In this case, it's myocarditis, who was vaccinated on May 30th and had the outcome on June 30th, which was within the risk interval 1 to 21 days. Now this individual was compared with another individual, vaccinated individual, who on June 3rd, on the same calendar day, was now in the risk interval because that individual, had been vaccinated on May 3rd. And so they are now in the comparison interval, 22 to 42 days. And so they are compared, and we use similar comparators. And by that, we mean that they're in the same age group and they're on the same sex, race, and at the same VSD site. And so we did this for every outcome on every calendar day. And this is for all the analysis that I'll show you. This was the analysis that we used. Okay. So now getting into the results of the surveillance of COVID-19 vaccine safety in children 6 months to 4 to 5 years. So this safety surveillance, the surveillance period began when children of this age group were authorized for vaccination recommended. And so the period went from June 18th, 2022 to March 18th to 2023. That was when we ended surveillance. The population included approximately 550,000 children of the VSD under 5 years of age. We use a pre-specified signal of a one-sided p-value of less than 0.011 as a safety signal. And we chart reviewed all cases of myocarditis, pericarditis, if they occurred, anaphylaxis, multisystem inflammatory syndrome in children, and other selected outcomes if necessary. So this is the uptake in the children over time. And you can see the 3 doses for the Pfizer vaccine in blue and the 2 doses for Moderna in blue. And generally what you can see, if you look at the bottom, it was, as we saw from many other vaccines, for the different age groups with COVID-19, it was fairly rapid uptake very early on, and then it quite quickly tapered off, and this was a pattern we've seen consistently throughout. But I think what's also important to note is that the uptake has really been not very great. I think that's fair to say, that we had a total doses of 275,000 doses for the population. So next I'll start. So this is the findings from the rapid cycle analysis, and this is the 1 to 21 day risk interval for the 6-month to 4 to 5-year-olds using the vaccinated concurrent comparators, again comparing days 1 to 21 to days 22 to 42. Now this is a very busy slide. I know you can't read this, but we can focus here on the final column, and what that says, even in print's a little small, it says no for all the outcomes. There was no safety signal for any of the outcomes. And this right here, and this is an overview of what this was actually published in June. What this said was that what we found was that among children 6 months to 4 to 5 years, there was no safety signal for any outcome in the 21 days after the primary series. There were no cases of myocarditis or pericarditis after vaccination. There are no cases of anaphylaxis related to vaccination. But as I mentioned, the vaccine uptake has been low. So I wanted to also spend a little bit of time talking about the surveillance of COVID-19 vaccine safety in children 5 to 11 years. So this right here is a summary. Again, we use the same analytic framework as I told you, the vaccinated concurrent comparators. And this is the findings in the 1 to 21 day risk interval for 5 to 11-year-olds. Compare the outcome events on days 22 to 42 as the comparators. And this is for the this was for the primary series. What's highlighted or in the red box is you can see the myocarditis, pericarditis, and you can see that those are all no's. There was no signal for the myocarditis, pericarditis. And actually, among children aged 5 to 11 in the VSD, no outcome met the signaling criteria in the 21 days after primary series vaccination. So here is just a few, this is just a few more outcomes that we looked at in this age group. So we also looked at chart confirmed anaphylaxis rate in 5 to 11-year-olds, and what we found was a rate of 2.8 confirmed cases per million doses. And just as a reminder, it's not in this slide deck, but in other analysis that we've done in adults, we found for the primary series an anaphylaxis rate of approximately 5 cases per million doses. And so as I mentioned, the uptake in I didn't mention actually, so the uptake in 5 to 11-year-olds has been 43%, a little better than the very young children, for 1 dose, and 38% have received 2 doses. And these findings were summarized in this publication you can see here I've included for your reference. So moving to the safety of the monovalent booster in children aged 5 to 11 years. So again, this is a summary of the rapid cycle analysis findings, one of the monovalent booster in 5 to 11-year-olds comparing during days 1 to 21 risk interval with a comparison interval 20 to 42.8 vaccinated current comparators. And what you can see here was that a couple things to point out, that here we have only 108,500 doses, so substantially lower than we've seen for other vaccines for this age group in terms. But we found among children aged 5 to 11 in the years in the VSD, no outcome met the signaling criteria after the monovalent booster. There were no cases of myocarditis, pericarditis in the 7 days after vaccination. And then, as I mentioned, vaccine uptake was low. And then just a brief word on the safety of the bivalent booster in children aged 6 months to 11 years. So this is a busy slide. It's showing the summary findings of the 1 to 21 day risk interval after the bivalent booster. Now the slide includes 6 months to 64 years. So, but I've put a box around here. The upper rows up here show the 1 to 21 day risk interval outcomes for the 6 months to 11-year-olds. And you can see that those are all no, and that there are no outcomes that met the signaling criteria after the bivalent booster in the 6 months to 5-year-olds. 6 months to 11-year-olds. So just to mention a little more about myocarditis, pericarditis. So here is a incidence rate of verified myocarditis and pericarditis in the 0 to 7 days after mRNA vaccination. And this was included 5 to 39-year-olds. And that was because, I think as you're probably all aware, the adolescents and young adults were the ones who are at greatest risk of myocarditis after COVID-19 vaccination. But it does go down to age 5 to 11. So just included this to just, again, show that in you can see the incidence rates for the 5 to 11-year-olds after the primaries, after the dose 2, 14.4, which is substantially lower than the other age groups, and that after the first booster, again, there were no cases in the 7 days after vaccination in the 5 to 11-year-olds. Now, I just want to make a brief note, mention of multi-system inflammatory syndrome in children. Now, we have been monitoring it. It's not a sequential monitoring once, but we've been doing descriptive analysis. And so just to present, and we did chart review all cases of MIS. So this is a summary of chart of our MIS-C cases in the after COVID-19 vaccination. So there were 33 total potential multisystem inflammatory syndrome cases of all ages that we identified post-vaccination. There 19 of the 33, so 58% of all cases were confirmed following chart review. And of those 19, 15, so 79% were confirmed MIS-C or MIS-C in children, and then that meaning that they're all under 18 years of age. So some descriptive from the chart views, we did no analysis, but the timing of the MIS-C relative to COVID-19 vaccination. First off, all 15 received Pfizer-BioNTech vaccine. Approximately a third, or 5 cases, had COVID-19 infection, then vaccination, then the diagnosis. 20% had vaccination, then infection, then the diagnosis, and then 20% had vaccination, known COVID-19 exposure, and then the diagnosis, and then a variety of other sort of, timing related, all sorts of different timings for the rest of them. So overall, more than 86% had some combination of known infection and vaccination. And in terms of the clinical characteristics of the confirmed cases, the median age was 7 years. 80% were male, and 60% required intensive care stay units. And then the Brighton levels, so 80% or most were level 1. So to summarize this findings of safety findings after COVID-19 vaccines in the VSD, among children 6 months to 4 to 5 years, there are no safety signals for any outcome in the 21 days after mRNA primary series. There were no cases of myocarditis, pericarditis after mRNA vaccine primary series. Uptake has been low in this age group. Among children 5 to 11 years, there were no safety signals for any outcome in the 21 days after both mRNA primary series and the monovalent booster. Among children 6 months to 4 or 5 years, there were no related cases of anaphylaxis after vaccination. Among 5 to 11-year-olds, the rate of anaphylaxis after the primary series was approximately 2.8 cases per million doses. And then there were 15 confirmed cases of MIS-C after vaccination, and most, 86%, also had COVID-19 infection. And with that, I'd like to acknowledge how much it takes a village to do all this work for these years. And this is really most appreciative to all the large numbers of people who have contributed greatly to this effort. And these are acknowledge all the VSD sites. In particular, the first line shows up the pediatric paper authors. And I think with that.
Well, thank you, Nikki. We appreciate you being here with us and appreciate the very reassuring report about myocarditis in our youngest kids. I think, again, emphasizes that we have an opportunity for protection of a lot of these kids against COVID-19 that's been unrealized to this point with a very safe and effective vaccine. And I also want to thank Dr. Daly. Matt, the follow-up of our routine childhood immunization process, while we think of it as being a safe and effective process, continuing to do observational review and is going to be important to help reassure parents going forward. Are there any other questions or comments from either those in the room or community members online? Chris Harrisman, please.
Thank you. Thank you for your presentation, and as Dr. Hopkins said, for the encouraging information. I'm just wondering how we can get this information out more broadly, and not only the positive information, but the fact that, for instance, with the first presentation, how parents had expressed concerns, those concerns were heard, there was the IOM report, there were these subsequent studies, and then the findings. I think that the public needs to know that they're being heard, that action's being taken, and then in fact, once studies are done, that it does reinforce the safety of vaccines. So I'm encouraged by the findings, but also really concerned that we can get this information out to parents in a broad way so that they see the responsiveness of the system. Thank you.
Matt or Nikki, either one of you want to comment?
Matt, I'll go ahead and let you take that one first.
Okay, thanks. Yeah, I mean, Dr. Erzman, that's a great question, and it's one we've thought about quite a bit. I think as complex as it is to study the safety of the schedule, I think it's equally complex or more complex to actually then communicate those findings. And as we all know, negative safety studies generate less attention than do positive safety studies. And so certainly, we tried to communicate the findings of those first two studies that we talked about and how they fit into this longer, broader process. But I think we need to continue to sort of do a better job with doing that. I think the fact that this was also presented, the presentation I gave today was similar to a presentation I gave at the June ACIP meeting, and that's also a good public forum and discussion for that. But then it also brings up the challenge with that third study. Again, the findings were unexpected, hard to communicate that there's sort of more investigation. I think at the end of the day, we'll get additional data that, again, either sort of refutes those findings and provides additional reassurance or not. But in the meantime, that's also a hard message to communicate. There's lots of reasons to have confidence in the safety of aluminum when used in a vaccine too, for a whole variety of reasons that we didn't have time to go over. But that's also a challenge to communicate. So I think, if you have suggestions, but I would acknowledge that it's hard to communicate, particularly when it's a long process. And then when we have these what I'd call negative studies or reassuring studies, they also get less attention than perhaps they should.
Daniel Hoft.
Thanks, Bob. Enjoyed both of your presentations. My questions, I guess, are for Dr. Daly in relationship to the aluminum possible signal. I'm wondering if, I know you set out to study the cumulative exposure and association with asthma, but I wondered if you could use other vaccinations that aren't adjuvanted with aluminum and look at, is this a specific thing related to aluminum adjuvants or vaccination in general? Or would that be a good control for you? The other question I have is, I'm not aware of this, but are there any data in the literature that if you give a vaccine that is adjuvanted with alum, you would increase the Th2 responses of, to allergens in any way? Has anyone generated that type of data to support this rationale for why you should study this?
Yeah, so great question. So taking the first part of your question around comparing vaccines with an aluminum adjuvant to vaccines without an aluminum adjuvant, that's not possible in the first 24 months of life because, for example, DTaP containing vaccines have aluminum, and there are not DTaP containing vaccines with no aluminum. And so, there are vaccines that do not contain aluminum, but not of the same vaccine type, like a DTaP vaccine. So that part is not sort of feasible as sort of a comparison. But I understand sort of underlying your question is sort of how do you find a good comparison group for those who have higher aluminum exposure, vaccine-associated aluminum exposure. And then to your second point, so as I mentioned, there is some biologic plausibility to this hypothesis, but it's pretty limited. But there are some animal studies, including mouse studies, where you can look at essentially sort of the immune fingerprint of a Th2 type response. And in those studies, it did appear that some aluminum exposure, again, sort of injected aluminum in mice, did skew an immune response towards a type 2, Th2 type response. However, kind of when we've discussed this with our colleagues at the NIH, they felt like, there's enough differences between a mouse immune response and a human immune response that they felt like you really shouldn't sort of take that as very strong evidence that there's biologic plausibility there. Again, the sort of immunologic differences between mice and humans were sufficient enough that they felt like that wasn't necessarily really strong evidence. There still is this public concern out there about ingredients, including aluminum. But again, the biologic plausibility for the hypothesis is fairly limited. Thanks.
Well, I want to thank Dr. Nikki Klein and Dr. Matthew Daly for your presentations today, for your contribution to NVAC. We're now going to turn to break. I now have 10:43 Eastern Time. We're going to return at 10:47 Eastern Time. We're going to do a short break, and then we'll jump back into our next panel, which is Proudly Pro-Vax, Trusted Messengers Speak Up. Thank you for joining us for NVAC today.
Produced by the U.S. Department of Health and Human Services.